Thank you, Professor Chidi, and good afternoon, everybody. It's my pleasure to talk something about the liver resection for early HCC. The treatment of early HCC is an important issue, and the liver transplantation, liver resection, and percutaneous ablation are the main three options for the early HCC. However, the liver transplantation provides an alternative, creative option for the early HCC. Its implication is still limited by the shortage of donor, of the liver donors. Liver resection or percutaneous ablation is more commonly used. The BCA staging systems recommended that the liver resection only suitable for the patients at the stage 0 or stage A. So this indication has been beyond by a lot of surgeons. A Western series supported that the 5-year overall survival of 81% achieved for patients with a single less than 2 cm in diameter HCC and platelet count more than 140,000. So they conducted that the liver resection should be a primary modality for small liver cancer and will preserve the liver function. One randomized clinical trial from China, they reported that the HCC less than 4 cm in diameter and the number less than 2 ablation was equivalent to liver resection for survival, but with increased local recurrence rate. So they concluded that a small HCC located at a specific sites, open and lap liver resection is better choice, similar to the previous another Chinese author, he published his first randomized data on the issue in 2006. A recent study from Italy suggests that the cost and effectiveness of a liver resection and the radiofrequency ablation. This concluded that for very early HCC, 2 or 3 nodes less than 3 cm in diameter, ablation is more cost-effective than resection. For a single larger HCC, liver resection remains the best treatment. A systemic review and meta-analysis also suggested that the difference in the short-term effectiveness of radiofrequency ablation and liver resection in the treatment of early HCC is not notable, but the long-term efficacy of the liver resection is better than ablation. So let me make a brief summary. The liver resection might be considered as a primary therapy for early HCC with well-preserved liver function, particularly for those without cirrhosis, and the tumor had a favorable location in the liver. For early HCC less than 3 cm in diameter and multiple less than 3, ablation may be more cost-effective, especially for patients with high surgical risk. The long-term prognosis of liver resection might be better than ablation. So, however, the comparison the indication between the liver resection and ablation is still a controversial issue regarding the tumor size, member location, and underlying liver diseases. So which groups is in early HCC is more suitable for liver resection or ablation is still controversial, remain to be determined. A SCAI system may have some, the prognostic model have some practical meaning to predict the outcome after the treatment, after the liver resection or ablation. The Netherlands study suggests that they constructed the scanning system, and you can find that there is a significant difference in overall survival for the patients with different scar. So in our study, we conducted a prospective cohort study about the liver resection for HCC within Milan criteria. The Milan criteria used in our studies not only just mentioned this patient suitable for liver transplantation, but importantly, we just use Milan criteria to describe the stage of the HCC. The patient with HCC within molecular undergoing liver resection between 2000 and 2011 at EHBH were prospectively corrected. Early treated patients formed the training cohort, and the later patients confirmed the internal validation cohorts. And the patients operated at the Liver Cancer Institute of Fudan University were used as the external validation cohorts. So this prospective cohorts, including the two largest cancer centers in China. Diagnosis of liver resection. Prospective HCC diagnosis meet ASD criteria. Liver resection was considered if all tumors could be technically resected within liver functional reserve. And types of liver resection was based on the liver function, tumor distribution, and estimated value of future liver remnant. Anatomical resection was preferred. In criteria where HCC within Milan criteria, preoperative had a good general performance, Chad Paul class A, no anti-cancer treatment history, no extrahepatic metastasis and major vascular invasion, and complete resection of tumors and histologically proven HCC on the surgical resected specimens. This is a flow diagram, and finally, a total of 2,244 patients was included in our study. Results. We had 23 variables which was used for the analysis of clinical pathologic analysis, and no significant difference was found among three cohorts. Prognosis. The 5-year recurrence rate was about 80% in these three cohorts. And 5-year overall survival is about 40% to 45% in these two cohorts. There was no significant difference. The independent predictor evaluation suggests that the HBeAg positivity, more tumor number, multiple tumor, larger tumor size, MVR presence, absence of tumor capsule, surgical margin, and higher HBV load with the independent predictor of tumor recurrence for overall survival, and higher serum, besides of the same predictors, the higher serum AFP level and cirrhosis was the independent factor. On the basis of the above study, we developed two nomogram. The nomogram was a practical tool to predict the prognosis of many types of malignancy. And our previous studies also suggested that the monogram is a very good predictive tool in intrahepatic cholangiocarcinoma. So in this study, we just want to develop the test whether the nomogram can provided a higher performance in such prediction. And also our results suggest that the good predictive performance based on C indexes was obtained. Also, this is an overall survival nomogram. It produced very good and based on the C index analysis. The correlation curves showed that there showed optimal agreement on tumor recurrence and patient's survival between the prediction by the nomograms and actual observation in these three cohorts. So this just suggests that there are a good match between the prediction and actually clinical observation. The conclusion in this study, liver resection achieved 5-year overall survival, more than 40% in patients with HCC. That was relatively earlier HCC. 5-year overall survival could reach 80% in subgroup with single tumor less than 3 cm, well-preserved liver function, and without microvascular invasion. Besides of tumor and surgical factors and cirrhosis, Higher HBV DNA load and MVI presence decreased the surgical prognosis of early stage HCC. Our proposed nomogram provided accurate prognostic prediction. So this is just identified or confirmed by the C-index analysis. Also, I just used the few slides to introduce some liver resection. Our study in liver resection for early intrahepatic HCC recurrence. This is also the early tumor. Especially it was not the primary, but the recurrence after the initial liver resection. So we had 1,225 patients. The recurrent HCC within military criteria was included. The exclusion criteria were where the initial preactive resection, poor general condition and poor liver function, PVTT intrahepatic dissemination, extrahepatic metastasis, incomplete clinical data, and hospital mortality, and lost follow-up. Finally, 596 patients was met the above criteria were further analyzed. We compared the hepatobiliary and radiofrequency and the TACE regarding their outcomes in the treatment for the HCC recurrence following liver resection. The endpoints was overall survival and the recurrence-day survival. And this is overall survival, this is the RTDS, and shows that the lumpectomy group presented the highest survival rate, both for the OS or RTDS, and followed up by the radiofrequency ablation. But the lumpectomy is significantly better than radiofrequency ablation, both for the overall survival and recurrence to death survival. The multivariate analysis showed that the treatment for recurrence, the treatment method for tumor recurrence, I just analyzed the hepatobiliary and the radiofrequency ablation, also the TAC. I just omitted it because my topic is just for compared these two procedures. It was found that the literature was set up one for hepatobiliary and the radiofrequency ablation produced a literature is about 1.69, but the difference there is no significant difference. The statutory analysis based on the independent factors, presence, absence, it was just wanted to study or observe the association between the presence, absence of each independent factors and prognosis following treatment of hepatobiliary and radiofrequency ablation. If there was no significant NAs, it showed that in this situation, the hepatobiliary and the ablation had similar results. Otherwise, you can check which one was better. So this study was just wanted to check the proper indication for these two procedures. So my result and conclusion was hepatobiliary was still better than radiofrequency ablation for relatively early intrahepatic recurrence following liver resection. With positive ALP, these patients may be suitable for the hepatobiliary, such as positive AFP, highly differentiated primary tumor without varices and solitary recurrence. Hepatobiliary was similar to radiofrequency ablation for negative AFP, poorly differentiated primary tumor with varices, time to recurrence longer than 12 months, and multiple recurrence. This suggests that radiofrequency ablation might be a primary choice in this situation. So, thank you for your attention.